everyone, and welcome to Ovarian Cancer Australia's Information and Support webinar. My name is Vanessa Alford. I'm part of the support team at OCA. I'd like to begin by acknowledging the traditional owners of the land that we're on and pay my respect to elders past and present. This webinar is supported by an educational grant from Roche Products, for whom we are extremely grateful, especially during these challenging times. We're so grateful that we can continue to provide resources and support our women. The focus of this webinar will be on the latest developments in ovarian cancer. We have three incredible presenters who are going to share some valuable information with you. The webinar is interactive, so over the next hour, you can ask questions to the presenters by using the dark blue hand icon at the top of your screen. Questions will be answered at the end of each presentation. Please note that presenters cannot address individual medical cases. If you do have a question, please call the Ovarian Cancer Australia Information and Support line on 1300 660 334. This webinar is being recorded and will be posted on the Ovarian Cancer Australia website. For technical assistance during the webinar, please phone Redback Support on 1800 733 416. So I'm extremely privileged to introduce our presenters to you. Our first presenter is Professor Michael Friedlander. Professor Friedlander is Conjoint Professor of Medicine at the University of New South Wales and a medical oncologist at the Prince of Wales Hospital and Royal Hospital for Women. Over the course of his career, he has had a leading role in gynecological cancer clinical trials nationally and internationally, and has co-authored 400 publications and received numerous awards in recognition of his contribution to gynecological oncology. He has been closely involved since 2007 in the early and late phase trials of PARP inhibitors in ovarian and breast cancer. In this webinar, Professor Friedlander will talk about the current role of PARP inhibitors in ovarian cancer. Our second presenter is Dr Yoland Antill. Dr Antill is a medical oncologist and cancer genetic specialist at Frankston Hospital, Royal Melbourne Hospital and Cabrini Health. Her interests are in the management of breast and gynecological cancers. Dr Antill is involved in the development and conduct of clinical trials and has published over 30 papers in international journals. She has more than 15 years' experience in both medical oncology and in the diagnosis and management of hereditary cancer syndromes. In this webinar, Dr Antill will focus on germline and somatic genetic testing in ovarian cancer. And our final speaker is Kristin Young. Kristin was diagnosed with stage 3C ovarian cancer in September 2009 and has been on clinical trials for much of that time. Kristin hopes that raising awareness of clinical trials and research will lead to more women benefiting from new treatments the way she has. In this webinar, Kristin will share her experience of being involved in clinical trials and what it has meant for her. So I'd now like to hand over to Professor Michael Friedlander. Thank you, Professor Friedlander.
Thank you very much for the introduction, and hello to everyone out there, and hope you're all doing well and in self-isolation. I'm going to be talking about PARP inhibitors in ovarian cancer, and I'm going to try and talk without the distraction of the echo that is coming through, which is difficult, but nonetheless I'll do my best. I've sort of been working in the field of PARP inhibitors for about 13 years, and I think without sort of exaggerating, I think they really have made a big difference and hopefully will continue to make an even bigger difference as time goes on. What I'm going to try and talk about in the next 15 minutes is just really give you a general overview. I'll firstly try and provide some insight as to how and why PARP inhibitors work. I'll talk very briefly about a concept called homologous repair deficiency. I won't go into great detail, as I know Yoland will be talking about this as well, but this is just one of the mechanisms whereby cancer cells repair DNA damage. And it's critically important because it explains why many cancer cells, in particular ovarian cancer cells that have this deficiency, are more sensitive to PARP inhibitors and indeed also probably to chemotherapy as well. And we'll talk about the relationship between BRCA mutations and PARP inhibitors. And then I think it's important to have a few definitions because we use terms like progression-free survival and median progression-free survival quite loosely. And it's important that people understand what we're talking about when we use these terms because many of the clinical trials are reported in terms of progression-free survival. I want to just go over that briefly. And then I will discuss what the recent trials have shown and focus on maintenance therapy in particular because I think that's probably the most important emerging role of PARP inhibitors. We also need to discuss the downsides of treatment, and as you will all be well aware that all the treatments we administer and prescribe do have potential benefits as well as potential side effects, and these are important and can impact on quality of life. And then at the very end, I'll talk about where we're going with PARP inhibitor research. The fatal flaw in breast cancer mutated cells is a deficiency in DNA repair. And this indeed leads to the increased risk of developing cancers in people who've got BRCA mutations, but also makes them exquisitely sensitive to PARP inhibitors. So this for me is really a very, very good example of a targeted therapy because it's targeting a specific deficiency in a tumor cell and without necessarily affecting normal cells. Obviously, there is some collateral damage, which we'll discuss in a moment, but essentially it's targeting the tumor cells. The development of PARP inhibitors has been really, really rapid. I know 13 or 14 years doesn't sound like a long time. It sounds like a very long time, but in fact, in the development of new drugs, it's actually a very short time. So only really in 2005, there were two, what I would call seminal critical papers that were published back to back in one of the most eminent journals called Nature that demonstrated that BRCA tumor cells, these are cell lines, were exquisitely sensitive to PARP inhibitors, whereas tumor cells that did not have a BRCA mutation did not appear to be affected by the PARP inhibitors. And those two papers changed the way we thought about ovarian cancer very, very rapidly. And within a year or two, the phase 1, the very early development studies started with PARP inhibitors. And over the last 13 or 14 years, there has been very rapid progression through what phase 1 to phase 2 trials, where we tested PARP inhibitors in women with much more advanced recurrent ovarian cancers. And when we found that there was benefit in that situation, then we moved on to the maintenance setting, and I'll talk about that in a lot more detail. But hand in hand, or coincidentally with the development of PARP inhibitors, our knowledge about BRCA mutations, our knowledge and understanding about the biology of ovarian cancer, and specifically the fact that not all ovarian cancers are the same, and how in particular BRCA mutation carriers are very sensitive to PARP inhibitors, and we also recognized and understood that tumors that had deficiency in repairing DNA, so-called HR deficiency, were also very sensitive. And that sort of changed the way we thought about using these drugs. But before moving on to that, there's just some very fundamental basic concepts. I have simplified them, but I think hopefully we'll get the message across. So if we consider a woman who's got either BRCA1 or BRCA2 mutation, something she's inherited, in other words, she has a germline mutation, what that means is in every single cell of her body, she has a normal copy of BRCA1 or 2 and a mutated or non-functioning copy, and that's reflected in the diagram that you can see in the slide. So one copy is mutated and non-functioning, and one is functioning. So in that cell, BRCA function to some extent is retained, and the main role of BRCA is to repair DNA damage. So those cells still have the ability to repair DNA damage. Now, when a cancer develops, in the tumor cells, there's no functioning BRCA. So in other words, there's a mutated BRCA that's been inherited, and the other normal, inverted commas, BRCA gene has either been lost or mutated. So in the tumor cell, there is loss of function. There's no BRCA gene that is functioning, and the protein that these genes produce is not present, and this results in disrupted, abnormal DNA repair. And because these cells cannot repair DNA damage using the normal mechanisms, they rely on backup mechanisms, which are not particularly effective or good, and this explains the sensitivity to PARP inhibitors, as shown in the next slide. So on the left-hand side, you've got your BRCA function, and you've got your technicians who know how to repair the damage. On the right, you've got your backup crew who come in and help repair the damage when your main crew are not available. And so in a normal cell, when you treat with a PARP inhibitor, we know that normal cell can still repair DNA damage because it's got a normal functioning BRCA gene, and those cells are not affected by a PARP inhibitor. And in a cancer cell that has lost BRCA function, it relies on the PARP enzymes to repair DNA damage. So this is the backup crew. And if you inhibit that particular enzyme with a PARP inhibitor, in other words, get rid of your backup crew, then when DNA damage occurs, it cannot be repaired and the cell dies. It's sort of as simple as that. I know it's kind of oversimplified, but essentially that explains why PARP inhibitors work on BRCA-related cancers, and also you'll see in tumor cells that exhibit this deficiency of homologous recombination repair. Because this is also a very important mechanism whereby cells repair damaged DNA. And so BRCA mutations are a very good example of faulty DNA repair, but there are many, many other mechanisms other than BRCA mutations which can also lead to this repair deficiency, and tumors with this homologous repair deficiency are more sensitive to PARP inhibitors. And this allows us to try and work out who should be treated with a PARP inhibitor. Now, I'm only talking about ovarian cancer, but PARP inhibitors work in many other cancers as well. So we know that not all ovarian cancers are the same. Indeed, there are many, many differences between different cancers, and even within the more common or the most common type of ovarian cancer, which is called the high-grade serous cancer, there are multiple variations and variants, and we know that about 50% of high-grade serous cancers have a deficiency in DNA repair. And of those, about maybe 15% or so have BRCA mutations. So those are the tumors that I'm going to be more sensitive to PARP inhibitors, and the ones that will benefit from treatment or potentially benefit. So now I'm moving to definitions, because you need to understand these definitions when you're reading the results of clinical trials. The way that we measure benefit, and I think it is controversial, but nonetheless this is the way we do it, is looking at what's called progression-free survival. And this measures how long patients live without evidence of the cancer growing or spreading while on treatment, compared to the group of women on the control or placebo. And we measure recurrence using CT scans, which we do every 3 months or so. And if there's evidence that the cancer grows back or increases in size, or the patient develops symptoms of progression, that is then termed progression, and that's how we measure progression-free survival. And then what we report in clinical trials is the median progression-free survival, which is the length of time from the start of treatment that half of the patients have not progressed. So that's really important to understand, because it helps interpret the results of trials. So when should we use PARP inhibitors? And they've been looked at in a number of settings, and I'm going to talk about them each briefly. Either as treatment alone in women with recurrent ovarian cancer, and that's where we first started using PARP inhibitors in clinical trials, or as maintenance therapy after response to treatment in women with recurrent ovarian cancer, And more recently, we've been looking at PARP inhibitors after first-line chemotherapy. And the current generation of clinical trials that we're doing are combining PARP inhibitors with other drugs, immunotherapy drugs, angiogenesis inhibitors, and so on and so forth. So there are lots and lots of trials going on at the moment. The initial trials focused on women with advanced recurrent ovarian cancer, often who'd had multiple lines of treatment, and we were able to show that PARP inhibitors did appear to work, and they worked much better in women who had not had a lot of chemotherapy and also had what was called platinum-sensitive recurrent ovarian cancer. The side effects appear to be less than chemotherapy, but in general, the duration of benefit was measured in months. And it was clear that we could probably do better than that. And from then, we came up with the concept of maintenance therapy. And this is based on a number of basic principles. First of all, that almost all women who have been diagnosed with ovarian cancer, who have had a good response to chemotherapy, will unfortunately relapse after stopping chemotherapy. And the duration of remission will get shorter with each line of chemotherapy. And on average, the duration of remission is usually less than 6 months. It can be a lot longer, but the median is around 6 months. And although further chemotherapy can be offered, the chance of it helping gets less over time. So the question was, if we gave PARP inhibitors after response to chemotherapy, could we prolong the duration of remission, and could we perhaps prevent the cancers coming back at all? And the first study that we did was called Study 19. And this included women who had had often many lines of chemotherapy and had responded to or re-responded to chemotherapy, and they were randomized to either get olaparib or placebo. And there was a striking difference in the median progression-free survival. It was almost a 3- to 4-fold difference in favor of the PARP inhibitor. And what was also striking was that about 16%, I know it's not a lot, but it's something that we hadn't seen before. It's really a substantial change. 16% of women on that particular trial were still on the PARP inhibitor without evidence of progression for over 5 years and continued on treatment. And that study then led to many, many other trials, which I won't go into great detail, but they summarize very briefly here, because essentially they all showed the same thing. And these trials demonstrated that, in particular, in women with BRCA mutations, there was a 3- to 4-fold longer duration of remission or delay in progression in women who were randomized to a PARP inhibitor. And that was seen in these 3 different trials using different PARP inhibitors. Most of the women who had BRCA mutations appear to have the greatest benefit, but even in the women who did not have BRCA mutations but had had tumors with the repair deficiency, the so-called HRD deficiency, there was also a benefit, supporting the role of maintenance therapy. But the real ultimate goal is it possible to increase or improve overall survival in women with ovarian cancer? In other words, once and done. So if you have chemotherapy and you go onto a PARP inhibitor, is it possible to prevent these cancers coming back? Now, that is the holy grail, but ideally, if we want to improve survival, probably the best chance is after initial treatment. And there have been 4 trials that have looked at the role of PARP inhibitors. The first one was called SOLO-1, and in SOLO-1, women with advanced ovarian cancer, after they had completed chemotherapy and responded to treatment, were then randomized to either olaparib or placebo. All these women had BRCA mutations, and it was called a 2-to-1 randomization. And what that trial showed very briefly was a very significant benefit in favor of olaparib. And at 3 years, 60% of women on the olaparib were progression-free compared to 27% for placebo. So a doubling in the progression-free survival. And we have limited follow-up. So Time will tell whether this treatment actually means that a higher or larger proportion of women will remain disease-free without recurrence. But this has really been quite transformational, and the important thing is that there were 3 other trials, similar but different, that were reported late last year. I won't go into great details apart from saying that they all also demonstrated that PARP inhibitors improved the progression-free survival, a very significant improvement, particularly in women with BRCA mutations, but also in women with tumors that had homologous recombination deficiency, suggesting that we can potentially change the natural history, if you like, of this disease. And this just shows you very briefly some of the findings. For example, the progression-free survival was more than 2 to 3-fold longer in women who were randomized to a PARP inhibitor. I won't go into great detail because of time. I'm going to move now onto the side effects of PARP inhibitors because that's very important. There are differences as well as similarities between all these PARP inhibitors. The most common side effects are nausea and fatigue. The nausea comes on pretty early, but usually, not in everyone, in most people, will improve within 4 to 8 weeks. Fatigue can be persistent and can be a long-standing problem for some women, for sure. Other side effects include vomiting, constipation, diarrhea, and altered taste. And anemia is the most common abnormality on blood tests and needs to be monitored for carefully. An important, but fortunately very rare side effect seen in the PARP inhibitor trials has been leukemia in about 1% or so of people. Now, this can also occur with chemotherapy in the absence of PARP inhibitors, but it's important to be aware of this, and we're still trying to learn a bit more about which women are more likely or susceptible to developing that very serious side effect. Regular follow-up is very important with clinical review and regular blood tests. And this slide demonstrates when these side effects occur. And as you can see, most of the side effects occur quite early with nausea, vomiting, and anemia, all tending to occur in the first few months, but can occasionally occur later. But it's generally in the first couple of months, and once you've got through the first few months of treatment, then things are usually okay for most, not for all people, but for many people. About 25% of women will require dose reductions, and sometimes we have to have dose delays and dose interruptions. So very briefly, PARP inhibitors, I think, have earned a place in the treatment of women with ovarian cancer. The greatest benefit we've seen has been in women with BRCA mutations, but non-BRCA-related cancers also respond, and the real challenge is to identify who these patients are and to work out what the best tests are. The greatest benefit appears to be with maintenance therapy after response to chemotherapy. Time will tell whether we can improve survival. There are side effects of treatment which require careful management, and the next frontier is combining PARP inhibitors with other drugs in the hope that we can change the outlook for many women with ovarian cancer. And I think I've gone a bit over time, and I'll stop there. Thank you very much.
Thank you very much, Professor Friedlander, for that valuable presentation. So much information there that will benefit us all. There's been quite a few questions, so I do apologise if we don't get to your question, but I will just ask a couple. The first one is, what is the current advice on the age that women who carry the BRCA2 mutation should have their ovaries removed to prevent ovarian cancer?
So I'm going to leave that to Yoland because she's going to talk about that in her talk.
Okay, fantastic. Another question, has there been an opportunity for oncologists to talk with drug companies about whether patients should or should not be taking PARP inhibitors if they contract COVID-19?
Oh, look, that's a really, really good question, and I think no one really knows, and I think it's something we have to be aware of and careful of. Probably the greatest risks in people who contract COVID-19 are age and other medical problems. We don't really know whether PARP inhibitors will make things better or worse. I'm certainly not make it better, but I don't think it'll make it worse. I think they're different to chemotherapy. So the answer is I don't know, and I don't think any drug company knows that answer either. But it would be prudent for anyone on any treatments to self-isolate and do whatever they possibly can to avoid getting COVID-19. But I'm sorry I can't answer that question because there's really no data on it.
Sure. Thank you very much. We will let you go, Professor Friedlander. Thanks again for joining us on this webinar.
Okay. Thank you. Bye.
I'd now like to bring to the microphone our second speaker, Dr. Yoland Antill.
So I'm hoping everyone can see and hear me. So thank you very much for asking me to speak tonight. So as it's already been outlined, I'm both a medical oncologist like Michael, but as long as I've been a medical oncologist, I've also been practicing in several family cancer centres in this area of cancer genetics. And I think ovarian cancer really is the poster child for the real meshing between the idea of an inherited risk or this targeted driving, these genetic targets that drive cancer development, and how pharmacotherapy can take advantage of that, and how far we have come. So what we're going to do today is actually cover what on earth genes are, and how are they relevant to ovarian cancer and ovarian cancer care. We're going to a little bit about the difference between familial versus tumour genes, and how cancer treatments can change according to their genetic profiles, whether it's either inherited or in terms of tumour-related genetics. And then how do you test for these genetic changes? So just some basic background, and I apologise to all on the webinar if you are a molecular biologist, but a lot of this is going to take us right back to very basic concepts. So a gene is our basic unit. It tells us exactly who our genes are, very short segments of DNA, and they're found in the chromosomes of all of our cells. Each gene contains a code that directs an essential production of protein that's very specific to that specific gene. So if we take ourselves into something more familiar, and particularly during COVID-19's isolation and home cooking, you can't get cake mix or flour or sugar in any supermarket at the moment because everyone's doing lots of cooking. Genes are kind of like the ingredients and a recipe that if is read from beginning to end in exactly the right order, and all the ingredients are exactly the right ingredients, then you'll end up making a beautiful cake. So the cake is the outcome of the functioning gene that is read from beginning to end. So what's inheritance? So we all have around 20 to 30,000 genes, and genes make up what our chromosomes are. Some of you might have seen little pictures of chromosomes. There's 2 copies each of the chromosomes, so 2 copies of each gene that we have. We get one from our mum and one from our dad, from the egg and from the sperm. Genes are who we are. They tell us how tall we're going to be, whether we're going to be sports, whether we're going to be bookworms, whether we're more going down a musical line, whether we're more of an engineering, whether we have a scientific brain. It tells us what eye colour we'll have, what hair colour we have, unless we get someone to intervene with that. It also even influences things like personalities, and other things can influence that, but genetics certainly play a very strong role, or genes play a strong role in everything and who we are. So what happens when a gene is abnormal? So in our recipe for our beautiful cake, if we just change 2 little letters, SR in front of flour, to a P in front of flour, you'll see that our beautiful, lovely cake turns into an absolute flop. And this very same thing can happen when there is a small change to the genetic code, it can lead to a very devastating outcome into what that gene was supposed to do in terms of protein production. So if we think back to genetic-related conditions or diseases, you can think of many. The obvious ones, and I guess one of the most common ones in our community that we see is this trisomy 21, so that is an additional chromosome of 21 leading to Down syndrome. We know of many families who are affected by familial heart disease or have high blood pressure. We know that diabetes runs in families. And there are some rarer but many thousands and thousands of genetic conditions that relate to abnormalities in our genes. So where does genes fit into cancer, and particularly ovarian cancer? So let's go back to our kitchen. So cancer is abnormal production of cells. So cells go through this normal process of what's called cell division. And it should be a very ordered process, much like washing up is. You start washing up with a pile of dirty dishes, you wash them in this hot soapy water, you drain them, and you dry them, and you put them away. But if something happens to change that nice ordered process, much like Merlin did when he tried to automate the process of washing up in the film The Sword and the Stone, then that whole process can become unregulated and very chaotic. So if we apply this to our cell division, here we have our beautiful normal cell. It's going through the division process to produce beautiful normal cells, what's called daughter cells, that are exact replicas of the mother cell. But if you have something happen and you have an abnormal cell or cell that contains abnormalities, then there are lots of checkpoints in place to be able to correct those. And if they're not correctable, then there are other mechanisms in place by which that abnormal cell is sent off to die, so that it can't go on and reproduce more abnormal cells. So what happens in cancer is that these abnormal cells are allowed to reproduce. And the more cell division that occurs, the more and more abnormal these cells become in future generations. And this is exactly what cancer is. It's normal cell division that has become abnormal and becomes so abnormal that it becomes self-regulating and self-growing. So our genes would normally act in here to both understand that there's an abnormality in a cell and, or if it can't correct, then send that cell to die. So this is when everything is functioning normally. But if our gene is not producing the normal protein, then it can't act here. And so these abnormal cells are allowed to grow and divide, and cancer risk is increased and cancers occur. So what happens if that abnormality in the gene is in our germline? So it's within the egg. It means that when that parent produces the child, every single cell in that body will also have that abnormality. It means that that gene abnormality is heritable. It can be passed from parent to child. In the case of these familial cancer genes, it means that that heritable risk for cancer can be transferred from parent to child. But what happens if the error in the gene actually just occurs along the way in the cells as they're growing and dividing? That's what's called a somatic or tumor mutation. So it's present in the cancer cells, but it's not present in the other cells in the body. It's not heritable, so it isn't something that can be passed on from a parent to a child. So genetic pathways influence normal cell growth in many different ways, and variants or mutations in these genes can also influence the normal regulation and normal repair pathways of cell growth, lead to uncontrolled growth, accumulated abnormalities, and genomic instability. So now we come to hereditary ovarian cancer. The likelihood of ovarian cancer, or the likelihood of any cancer being hereditary, varies with tumour type. If we look at ovarian cancer here in the middle, the chances of any woman with ovarian cancer, the chance of her having hereditary ovarian cancer is from around 10 through to 25%. It's actually one of the more common familial tumour types. If we look at colorectal cancer, only around 10%, and in breast cancer, only 5 to 10% are likely to be hereditary or familial. The sort of genes that are associated with hereditary ovarian cancer is varied, BRCA1 and BRCA2 being the most common. Mismatch repair genes associated with a condition called Lynch syndrome is quite rare but well recognized. Lee-Fraumeni P53 is the gene there, and then there are many other genes. The classic hereditary ovarian cancer families that we know and recognize are associated with the most common gene errors in BRCA1 and BRCA2. And these families, you'll often see other cancer types like breast cancer or prostate cancer or pancreatic cancer in the setting of a BRCA2 family. But we know from the Australian Ovarian Cancer Study, where 1,000 women who had ovarian cancer diagnosis who were tested for BRCA1 and BRCA2, of those women who were diagnosed with ovarian cancer in the setting of BRCA1 and BRCA2 mutations, 47% of them had no family history similar that you would see in these classic ovarian BRCA1 or BRCA2 family types. So we no longer in ovarian cancer rely on a family history. What we do is rely on the tumour type itself. We know that the proportion of women with ovarian cancer who have other hereditary ovarian genes does vary according to tumour type. So if you have high-grade serous ovarian cancer versus endometrioid cancer versus clear cell cancer or mucinous cancer, then the likelihood of these hereditary genes changes very much. But if we take the most common, that being high-grade serous, we can see that BRCA1 is the predominant gene, followed by BRCA2, with a whole host of other genes now well recognized to be representative of other genes contributing to hereditary ovarian cancer. How do we test for hereditary ovarian cancer? So you can either use a blood or saliva sample to examine for these genetic changes. Remember that these genetic changes, because they're heritable, are in every cell. So we don't just need to test the tumour tissue, we can test any cell from that particular individual. The results of genetic testing might influence the person's long-term management, and you've already heard from Michael how the initiation of PARP inhibitors after initial surgery and chemotherapy is now being used to maintain the effect of chemotherapy and improving the chances of cure or survival of their ovarian cancer diagnosis. But additionally, if a gene change is identified, then management and testing options open up for other family members. Genetic testing is funded if the chance of an abnormal ovarian cancer gene is more than 10%, which, as you know from that Australian ovarian cancer study, is absolutely true of all women under the age of 75. But in Australia, family cancer centres will offer all women with high-grade serous ovarian cancer a genetic test to understand whether their ovarian cancer has occurred in the context of a hereditary change for all women, not just those under the age of 75. Genetic testing usually starts in someone who has had a cancer, but not all people who've had a cancer will be eligible for a funded gene test, and this might relate to the type of ovarian cancer, particularly mucinous ovarian cancer, which is not likely to be associated with the BRCA1, BRCA2, or the other genes that are listed in the slides previously. The other thing that might influence gene testing in a family is whether the person who has been affected by cancer is still alive. And if the person is still alive, if they're actually wanting and willing to have genetic testing. So these can be influencing factors over ovarian cancer testing. We know that if someone is diagnosed with an underlying genetic change, and these, I guess, are the most common ovarian cancer genes, that they might be at increased risk of other cancer types, in particular breast cancer, in Lynch syndrome, bowel cancer, and uterine cancer. For males, it may be prostate cancer, or pancreatic cancer may be moderately increased compared to the general population. So where is genetic testing done? Traditionally, this has been offered through specialist genetic centres called familial cancer centres. But in more recent years, for women in particular who've been diagnosed with ovarian cancer, we've moved genetic testing into your local clinic. So your medical oncologist or your gynecology oncologist or your chemotherapy nurse might have offered you mainstreamed genetic testing. This is then followed up within the specialist genetic centres if there is in fact an actual mutation identified. So what are the inheritance patterns? Most of our hereditary ovarian cancer genes are what we call an autosomal dominant inheritance pattern. So we only need one parent to carry this abnormal gene for it to be able to be passed on to the children in a 1 in 2 chance for each child that is conceived from that parentage. But there are some very rare ovarian cancer genes, Bloom and Fanconi anemia genes, which require both parents to carry the abnormal copy for the child to be affected if they have both copies, abnormal copies from each of their parents. So is genetic testing for everyone? No. There are pros and cons to everything, just like there are in everything in life. The pros can be ruling out a high-risk gene. Is this something that just affects you, or is it something that is going to have impact for others in my family? Does it give me an explanation for why my cancer occurred? Can I give some reassurance to my children whether they are or they're not at increased risk for cancers? It might allow other family members to have a heads up that they are at increased risk and do something about that risk. So installing strategies to prevent cancers from occurring. But there are some cons. There can be some cons if an individual might not be eligible for gene testing, and she might need to consider paying for that gene test herself. It might not be a definitive test, and we're going to cover some this HRD concept or somatic or other reasons for tumour changes and susceptibility to PARP inhibition. The result might be confusing, a variant of uncertain significance. So this is where we see a genetic change, but we don't currently know in 2020 whether this does or does not affect the gene function. It might not change cancer worry. It might have insurance implications. And not everyone in my family might actually want to know. So what about these non-hereditary genetic changes? These are changes within the tumour cells themselves. So here, this might be somatic mutations. So this is acquired changes within the genetic code in tumour cells themselves. It impacts the normal function of the gene within the tumour, but it isn't hereditary. Promoter methylation is the silencing of the very start point of the gene. So it's like closing the book on the recipe book and not allowing the recipe to be read right from the very start. Again, that will affect that gene function, and it can be extremely rarely hereditary, but generally it's something seen just in these tumour cells. All of these somatic and methylation changes lead to this thing called homologous recombination deficiency that Michael's already alluded to. It's a very important part of the repair type of DNA damage involving many, many genes, including those that are well recognized to be associated with hereditary ovarian cancer. We know that germline, somatic mutations, Methylation, particularly of BRCA1, can lead to homologous recombination deficiency. And it probably explains a large number of those responses to PARP inhibitors that has been seen, but don't actually carry those germline mutations in BRCA1 or BRCA2. Can you have testing for homologous recombination? There are 2 companies that offered HRD testing, and they're open to Australian women, but it's done offshore. So it's done, both of these tests are done either in the US. So Myriad Genomics and Foundation Medicine are the 2 commercial available sites. Innovate may become, so Innovate was a study done in Australia that offered HRD testing within Australia, and the Innovate team are actually working on opening up the availability of HRD testing for Australian women within the Australian shores, something that will be very, very appealing, particularly as these tests rely on the US dollar, and our dollar at the moment is extremely poor against the greenback. So these tests cost around about $5,000 US, which is about $8,000 Australian at the moment. So it'd be good to have an Australian option. So these genes we know can guide the use of systemic therapy, and Michael's already alluded to the impact that it's had on PARP inhibitor sensitivity, so I won't go into that. But BRCA mutation and probably HRD and all the other genes that contribute to HRD also predict for prolonged response to the very first chemotherapy that's used in the treatment for ovarian cancer, carboplatin. So women who have BRCA mutations tend to respond to carboplatin again and again and again if their tumours relapse, become stable, relapse again and become stable again and relapse again, compared to those women who don't have one of these genetic mutations either in the germline or somatic. Just as a very quick sideline, we know that the Lynch-related tumours are associated with a different genetic pathway called mismatch repair deficiency, and this has also become very important in terms of immunotherapy. But I'm not going into that in any detail today because the main thing has been to talk about PARP inhibitors. So I'll take any questions if there are any now.
Thank you. Thank you very much, Dr. Antill, for that informative presentation. We do have a couple of questions. The first one is, when might HRD testing become available for Australians without that cost of $8,000?
So I spoke to some of the team leads in the Innovate study, and they're really hoping towards the end of the year that might become available for Australian women. The 2 other commercial options are available now, but COVID-19 has put some real brakes on any progression of clinical pathways, and that will be a clinical pathway, so it might be on hold a little bit longer because of the impact on healthcare systems.
Okay, thank you. Let's hope it is available sooner rather than later. And just another question. My mum had genetic testing done, but it came back inconclusive. Would you suggest we get the test done again, or should we, her daughters, get some tests done ourselves?
That's an excellent question. So all those other genes have been really added onto ovarian cancer panels in the last couple of years. So I guess it depends when your mum had her ovarian cancer genetic testing. And if it was many years ago, then it may be that her DNA is actually stored in the laboratory, and you might go back and ask the clinical team or the genetics team, would it be reasonable to look at the other genes that might be associated with ovarian cancer risk? But if that genetic testing has been in very recent years, then probably all those other genes have been on the genetic panel that was done. In response to the question about whether if more genetic testing is going to be done, should it be done in her daughters? No, I would still encourage that the genetic testing should be done in the person who's most likely going to answer the question for that family, and that is in someone who's actually experienced a cancer related to the genes that are being tested.
Great, thank you. Very helpful. Thanks again, Dr. Antill. We really appreciate your time.
Do I have time to answer the question that Michael deferred to me about the age of risk-reducing?
Sorry. Yes. What is the current advice on the age that women who carry the BRCA2 mutation should have their ovaries removed?
Yeah, so I'll just answer that pretty generally. So the age at which we would recommend someone to consider a risk-reducing strategy would depend on the gene error that was identified, so whether it was BRCA1, RAD51C, PALB2, but it also will depend on the family history. So generally, you would recommend around 5 years younger than the youngest person affected, or in relation to the gene that is known in the family. If there's no genetic change being able to be identified, then it comes back to the age of ovarian cancer occurring in the family members. So that would be something to take back to the Family Cancer Centre.
Great. Thank you very much, Dr. Antill. We really appreciate your time. Again, I apologise if your questions haven't been answered. We have had quite a few come through, but just due to time, we will move on to our third speaker. So I'd like to bring to the microphone Kristin Young. Thanks, Kristin.
Hi. Can you hear me all right?
Yes.
Beautiful. So my name is Kristin Young. I was diagnosed with ovarian cancer stage 3C in 2009. So you can see that's 10.5 years since my diagnosis, and 7.5 of those years I've been on clinical trials. So that's given me a chance to see the changes and developments in both research and in the new treatments, because of course the new treatments are born out of the research that's done. So I've been actively part of that era where the new treatments have started to spread out into the community from what originally being research studies and now being something that many more people can access and almost becoming standard of care. Also, I've always been interested in research as a way of solving problems. So I guess I was naturally drawn to being interested in clinical trials. So I had the standard sort of high-grade serous ovarian cancer, and I had the fairly typical initial treatment of surgery followed by 6 cycles of carboplatin chemotherapy. So I had a good long remission after my first treatment of 4.5 years, and I'll talk a bit more about that when I tell you about my first clinical trial. But as you know, the chance of experiencing a recurrence is pretty significant, and in 2014 that did happen to me. I decided to have a second surgery, and that's me on the left, sort of coming out of my second surgery and then in my chemo for my retreatment. So that's the last chemo I've had, because I have been on a clinical trial receiving a PARP inhibitor ever since then. So that's a very, very interesting story, which I'll tell you more about now. So when I was first going through treatment, it was really early on that my oncologist said, and when we finish your chemo, we'll look at a clinical trial. And of course, my ears pricked straight up because I'm kind of interested in research. And I think also that was a sense that I was going to be able to do something rather than nothing after my chemotherapy ended. So I was so keen that I found out all the details, and I went and approached the trial centre way before I was even going to be ready to do it. But I was so looking forward to it. And the other reason that motivated me then too was that I knew that when people finish chemotherapy, they often feel a bit lost. And the doctors happily send them away and say, congratulations, you finished your treatment. Now get on with your life. And on the patient side, it's, oh my God, what am I going to do? So I figured if I was on a clinical trial, I would have to have a lot more attention and people fussing over me and taking note of how I was going. So I really, that was a big motivation for me to go on the trial. The drug I did go on was anti-angiogenesis drug. It never did come to market. It did okay on the trial, but it just wasn't cost effective for the manufacturer, apparently, to bring it onto the market in Australia. And to this day, I don't know whether I was on the placebo or not. And interestingly, for that trial, I don't really much care, because the main reason I was on that drug was so I could get the attention, as I always say. So whether that contributed to my first long remission, I don't know. I will probably never know, but it may have. But then with my relapse, obviously things are different, and as anyone who's been through this knows, when you have recurrent ovarian cancer, your outlook changes, and you start to become highly motivated to do anything it takes, because cure then is not really one of the serious options. So I knew about PARP inhibitors already. I had already been identified as a BRCA2. The PARP inhibitors weren't available for people who were not recurrent at first, so that wasn't an option for me. I had to wait to recur till I could get that PARP inhibitor. Things have changed now, and you can get it first line. But I desperately wanted that drug, and I so wanted to be on it. So after my second surgery, I was very ill with a complication called chylosociety, and my chemo was delayed. The problem with this is that the Solo 2 trial that I wanted to get on for the PARP inhibitor, because at this stage it wasn't available on the PBS, was going to close on a certain date. And I had to get through 4 cycles of chemotherapy by a certain date, or else I would miss out on the PARP inhibitor, potentially, perhaps not forever, but I worried that if I didn't get on it, it could be life and death for me. So it was a bit of this race against time, and because I was so ill, my hemoglobin levels were too low to qualify for the trial. So just trying to get well enough. And then I remember that I just had to get those hemoglobin levels. So the night before my test, I dehydrated myself and ate a great big red juicy steak to make sure, and I got over by one point and qualified for the trial and started on the PARP inhibitor the following week. So that's 5.5 years. So really that's my life, and I really feel like I belong to something, I feel a bit, I like the feeling of being a bit special. I mean, AstraZeneca like me, because I'm doing well. There are some downsides for me. It's when you're on a clinical trial, you can't fiddle around with the dose, perhaps the way you would if you were getting it normally prescribed to you. Because if you dose reduce on a clinical trial, then you've got to stay on that low dose. You can't go back. So if you're having problems with side effects, it can be difficult to manage with dose reduction. You can only have short breaks off drug. So if you're struggling with side effects, sometimes a clinical trial doesn't give you flexibility to manage side effects. Another funny thing psychologically was a bit of survivor guilt too, because I was doing really well on the trial, and people in my support community, perhaps some were not doing so well, and I used to feel guilty that why have I been lucky to get this, and other people haven't been able to have access to it. But I then came to see that people could see that if I was able to be a symbol of hope, that at least somebody was getting a good new drug, even if they couldn't, that somebody was, and therefore there was some reason for optimism. And that optimism has turned out to be well placed, because more and more and more people are getting access to these treatments. But for me, the worst part of the side effects, because I was on a placebo trial, was I couldn't really prove that they were due to the drug. So I used to worry about this. Is the fatigue, is the lack of concentration, is this all in my head? Am I giving myself this because I'm thinking I've got those problems? Because it might be on the placebo, it may not be really side effects at all. So it would make me a little bit anxious, and I'd go into Prof and say, look, I worry because people don't believe that I really am fatigued. Because if I'm on the placebo, then I've got no reason to be fatigued. So I'm obviously making myself fatigued. So that's a bit sort of weird and psychological, but it was definitely a problem for me. But once I got to about the 3-year mark, it was pretty obvious that I must have actually really been on the PARP. Just because of the survival pattern I was exhibiting, I began to feel better about it. So my life is around these little fellas, and so all on a timetable. So what would I say to some other people who are thinking about clinical trials? The first thing I'd say is for some of the drugs that people are looking at now, really trials are a way to get access to drugs that may not otherwise be available. I mean, drugs like PARP inhibitors are available on the PBS for a lot of people, but there may be people who think or would have reason to believe that might be wanting to have those drugs, but they're not eligible for some reason or other to get them on the PBS, so maybe their only way to access these drugs is through a trial. So trials for many people in our ovarian cancer community are about access to drugs, not really about research. They're about how to get drugs that are otherwise too expensive to buy. But these days, as Prof was saying, there's so many trials now. There's, there's all interesting combination drugs. There's, earlier phase trials. And another thing there's a lot more of is compassionate access to drugs as well. The trick is always finding out about trials. It's not that hard to find out about the major trials, but there's so many little ones now, and no one oncologist, perhaps other than Professor Friedlander, can retain all of that knowledge in their heads, I don't think. So finding out about what some of the more smaller or unusual trials, you really have to, perhaps go and see a couple of different doctors and find out some more about it. Eligibility is a rocky road because you have to be eligible for a trial, because for it to be valid research, you have to study people that you can make realistic comparisons between the groups. So there are a lot of people who won't be eligible to join a trial. And being rejected for a trial can be quite upsetting and make you feel like you've been discarded or thrown away, or feel like you're missing out on something that other people have access to. And I think for a lot of people that can be really tough, especially if by their background they may have not had any reason to learn about how research is conducted and why trials are designed that way. So it can be an emotional roller coaster going through the eligibility process, because you can get quite a long way into the eligibility process and then still be rejected sometime down the track. So then the biggest question for most people is risk versus benefits. When you're in a recurrent ovarian cancer state of mind, you're pretty much, many of us are really going to want to try just about anything that will help. But as Prof said, these things come with side effects, and in some individuals, they can't tolerate these drugs at all. And there's also more subtle harms as well, is that, like for me, I've been on this for so long that I will never, in fact, return to normal. Like some people say, well, you finish your treatment, you'll eventually get better, you'll eventually return to a normal state. But for me, I'm on this long term. This is my normal for an open-ended period, who knows how long. I am a super responder now. I'm in that small cohort Prof was talking about that have the extended response, and we have no idea what the future holds. Once you're sort of 4 and 5 years into it, you start to think, is it worth it? Is it worth still putting up with this? Am I really getting, still getting a benefit? What if underneath all this I've actually been cured and I don't even need to be on this anymore? This, however, is a question that for which there isn't an answer. But having said all that about side effects, I would say that if you're faced with a chance to go on a clinical trial or one of these new treatments, and I see this on the internet forums, people expressing a lot of worries about, I don't know how I'll cope with the side effects of the PARP inhibitor. You know, my first reaction when I read that is say, well, just think about, you know, what's the alternative? And for me, I'm going to keep putting up with it because the alternative is perhaps not so palatable. And I'm not too worried about this. People say, I don't want to be in a clinical trial because I don't want to be treated like a guinea pig. I happen to like guinea pigs, and I did breed them for a while. This is a Shiba mini yak, and I had one of these. They're very nice. So I actually don't think there would be a bad thing to be treated like a guinea pig. I was very nice to mine. And just if people want to be part of the research community, but clinical trials are not available for them, there are other ways to participate in research, find out things and make a difference. And we're talking about the Innovate trial. It wasn't a trial, sorry, the Innovate study. I won't know much about it myself, but that's looking at people's characteristics of people's tumours. There was overseas, there have been studies on secondary surgeries. I had a second surgery. I would have loved there to be clinical trial data about whether it was worth it. There wasn't at that time. There's clinical trials about exercise. There's clinical trials about side effects, quality of life. There's a whole lot of ways to participate in research if you don't participate, in a clinical trial. So research isn't just about drugs. So I'm sort of use my blessing of having an extra lengthened life to try and do a bit of advocacy. This is Ovarian Cancer Awareness Month. But I don't know, obviously, what the future holds. Prof just shrugs when I say what's next. He doesn't know. No one knows. We are breaking new ground. But I'm very pleased to have been part of that revolution and, to be at the beginning of that and to see all the people that are coming on behind now and benefiting from the new treatments and all the creative new trials and new research. So that's me.
Thank you so much, Kristin, for sharing, your experience, your journey since being diagnosed, and your experience of being on clinical trials. There have been a couple of questions posted. One is, how difficult was it being on the trial and knowing that you could have been part of the control group and not actually receiving the drug? You touched on it a little bit, but with the last trial especially, how difficult was that?
With maintenance trials, it's not. One thing that's helpful to remind oneself is that if you're on the placebo, then you're just like anybody else who's not doing anything anyway. So really, you're not worse off than anyone else. The only thing you feel is, am I going to all this trouble for nothing? But the other thing is that there is evidence that being on a clinical trial, even on the placebo, does give benefits anyway. I don't know that it can show benefits in survival necessarily, but a heap of other benefits for people just because they are within a clinical trial. So I also, because I knew that, I also took the view that what does it really matter if I'm on the placebo? I'm getting all these other benefits. So yeah, that was my thought on it. It's probably still worth doing.
That's a great attitude to have, very, very optimistic. One other question, what side effects have you suffered, especially the long-term side effects? What have you experienced?
Yeah, well, just a quick point here. I just got unblinded from this trial 3 weeks ago, okay? So I have just literally found out after 5.5 years that I have been on the active agent all along. I haven't been on the placebo. That's new news for me, and I'm just coming to terms with that. That's great, because that means all those side effects I was suffering were actually real and not in my head, and I wasn't inducing them by, poor lifestyle or whatever. Though the downside is that now I feel like I'm on my own and I'm, not going to be looked after anymore. That's a false belief, but it's still an anxiety that I have. The main side effect for me is it's like any chemo, but about 10% of how bad you feel on normal chemo, just slightly out of it, like fatigued, a bit queasy, just like foggy in the head. I get some mouth sores sometimes. I get a bit dizzy. I'm lucky that I don't have the blood test problems that a lot of people have with this, the low hemoglobin and stuff. I'm lucky like I don't have that. I've never had anything complex with the side effects, but it's like being on chemo, but not as bad, because I periodically have breaks. When I have breaks, I feel like I get a big slab of myself back. You know, not my old self, but a lump of it comes back, and then go back on the drug, goes away again. But it's worth it, I think.
Well, thank you so much, Kristin. We really appreciate you giving up your time and just being so open and honest, in sharing your experiences. Pleasure. So I know everyone on the webinar will appreciate it very much.
Thank you.
So I do realise we have gone over time. I do apologise, but so much valuable information that we've heard tonight. So once again, I'd like to say a big thank you to our presenters, Professor Michael Friedlander, Dr Yoland Antill, and Kristin Young, for giving up your time. And, we know how busy you are, especially at the moment with all that's going on. So we're ever so grateful. Thank you to everyone who has joined us this evening. We really hope that you found it valuable. The recording of this webinar will be posted on the OCA website over the coming weeks, and you will also receive a link to the recording in the next week or so. In a moment, you'll be directed to an evaluation form. If you could please just take a moment to fill that in, because that really helps us to receive your feedback and helps us to plan for future webinars. If you have any other questions, please don't hesitate to contact our information and support line on 1300 664 330. This is obviously a very challenging time for everyone, and we know that many of you will need that extra support at the moment, so please don't hesitate to give us a call. Thank you again, everyone. We hope to see you for our next webinar, which should be in June. For now, please stay safe, stay well.